A simple Tylenol order takes up to 62 clicks in some electronic medical record systems. That's madness. And it's a key motivator for tech companies to combine artificial intelligence and voice recognition to simplify the process and reduce errors. Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group. My guest today is Emmanuel Bilbault, co-founder of POSOS, which is partnering with Microsoft's Nuance division to allow clinicians to prescribe by voice and get point-of-care treatment recommendations personalized to each patient. Welcome to CareTalk, Emmanuel.
Thank you, David. Very happy to be invited today and share with great news about the partnership with Microsoft.
Outstanding. Well, before we dig in, I'd like to encourage everyone to join the fast-growing CareTalk community on LinkedIn, where you can dig deep into healthcare business and policy topics, access CareTalk content, and interact with the hosts and our guests. And please be sure to leave us a rating on Apple or Spotify while you're at it. All right, I'll give people a second to do that. Now, Emmanuel, I want to start in the big picture and understand what are some of the challenges in electronic prescribing. I've been around long enough to hear, when they used to talk about the prescription pad and nobody could read the doctor's information. Now we got to electronic prescribing. Why are there problems?
Yeah, for two reasons. Actually, prescribing is a very complex process for the medical reason. First, the clinical reason, because prescribe a script for patients is making sure that every drug is compatible with each other. Like one by one, you have to check if it's compatible with the other drugs that the patient takes. You have to make sure that each drug is compatible with the patient condition, probably the patient renal function, patient disease function. Then you have to adapt the dosage to the patient weight, patient age. So it's a very complex process from a clinical perspective. But as you said, when software were developed to help physicians prescribe electronically, at the end, it's even more time consuming, because the very best EHR on the market is even like a crazy waste of time. You need at least 18 clicks to prescribe one medication. But you have to take into account that for the aging population, the average number of drugs in each script, it's 7. So seven times you have to decide which drug and click on the drug name. Then which galenic form, click on the one you want to select. Click on the strength, because there is different strengths and dosing for each drug. And then formulate the dosage, which means like how many tablets you take in the morning, for lunch, for dinner, for how long. So imagine like a long prescription for your grandmother or grandfather. It could take more than 10 minutes. That's why we needed to do something, and that's why we collaborate with Microsoft to help physicians save 10 minutes by patients. And
Okay.
we'll explain later why.
I mean, the thing is, if I consider, sometimes you hear about, well, doctors don't like technology, but I think a lot of it has to do with, they do like technology. They're big adopters of iPhones. They use a lot of things electronically, but I think it's the difference between what they see every day in their life outside of work versus work. So you mentioned, even if it's 18 clicks, I go to Amazon and they're famous for one click. I fill my shopping cart, boom, boom, boom. Doesn't take me 10 minutes to spend a ton of money. And so I think some of it is just like sort of, the disconnect. And I'm trying to understand, I get it that it's complicated, but it could also be complicated to buy something from Amazon. So, I mean, and Tylenol is pretty basic. If you even have to prescribe it instead of just grabbing it off the shelf. I mean, how could it possibly take that many clicks? I mean, where does that really come from? You did explain it in a way, but I only counted up to about the possibility of like 20 clicks. But how could it possibly take that many?
Yeah, that's complex interfaces, actually. I won't blame the software publishers for that, because there are so many different kind of prescription. I talked about tablets, but for some it's infusions, and you need so many options, so many possibilities to to cover the whole possibilities of a script, that interfaces are very complex. And that's why most of the medical software are moving to the voice, because with this voice, you can shortcut this process of clicking everywhere on the software. And that's maybe the only solution. The other one is AI, trying to predict which drug you will prescribe for a dedicated patient, and maybe generate options, suggestions for prescription, enabling physicians also to save time. Somehow with POSOS, we are combining both ways in one solution.
So let's talk about AI first. One of the reasons that there's so much excitement about AI in healthcare is that there's a lot of really challenging problems. And if you look at all these problems of, workforce, errors, quality, cost, we've been working on these things for decades. And you look at them and say, well, we've made some progress, but I think overall it's gotten worse rather than better in some ways. So you say maybe AI can be a solution, and it seems like that's possible. So if we look at AI first, and let's put voice off to the side for a moment, what is the biggest opportunity with AI in prescribing, or how does it address, some of those main issues that you talked about before?
I think AI is very interesting for health for one reason that somehow nobody really mentioned in the conversation around AI in health, is that medicine is not a perfect science somehow. And for exactly the same patient, you will see 10 physicians prescribing, like for instance, 10 scripts that are somehow different. And that means that there is no one solution or one great solution. There are many options. It's the same for diagnosis. For the same patient, you have like various diagnoses sometimes, and that's scary. But that's where AI is great, because AI is great in processing the probabilities, providing the best solution. And that's also why not only for diagnosis, because we talked a lot about diagnosis for AI, but also prescription. There are great opportunities to suggest the most tailored prescription for a dedicated patient, taking into account like all the patient history, comorbidities, current treatments, and making the best possible treatment for him or her.
Well, I talked before about the transition from paper-based prescribing to electronic prescribing. And while you resolved certain issues, like you could read the prescription's handwriting because it was now filled in electronically, you started to have new problems that you didn't have before. For example, with a pull-down list, I didn't have to worry I might have to worry that the physician would write something I couldn't read and it looked like something else, but you didn't have the issue that, because of alphabetical order, they would pull down something, one further down in the list that had nothing to do with what they were actually trying to do. Are there new problems like that with AI in prescribing? So maybe it's going to suggest something that nobody would suggest because it doesn't make any sense. Are there new kinds of problems that come up? And and if we don't know that yet, how do we know and how do we become confident?
The way you talk about AI means you're thinking about all the generative AI models somehow. And those models are very effective when those using it can just verify quickly that it's right or it's wrong. If you can't verify quickly the accuracy of the results, then you shouldn't use it. So that's basically the same for prescription. If the physician is well trained, he will be able to quickly identify that the options are relevant or not. So that's the way also we think about it. It's not like generating a prescription automatically and physicians just need to click and approve, but it's more about like suggesting options that the physician will check and select. But options means right treatment, galenic forms and dosage at the same time, more than just like generate a prescription automatically. And that's something close to the maps that we use and that were like transformed into a GPS. Sometimes in ways, for instance, you have 2 or 3 options and you select the one that makes more sense for you. That's the way we think about like the best AI for medicine, letting the physicians always make the final decision.
Okay, so if I use your Waze example, I know that I want to go from point A where I am to point B. And I know what point B is. Maybe it's a certain restaurant or a store or a person's house. In your analogy here, does a physician have to know the point B that they're going to? So, for example, do you take it as a given that the diagnosis that they have is the correct diagnosis, and you're only saying, given that diagnosis, here's these other ways to do it? Or is it a broader decision support where you're saying, given all the characteristics about this patient, you're writing a prescription for Tylenol, okay, but maybe it should be something else because maybe you should be treating something else. How far back does it go? How does it tie it into the Waze model there?
Yeah, we usually think about a patient with one pathology, one drug, but the reality is like a patient has several pathologies and several drugs in parallel. So when you want to prescribe one additional drug for a new diagnosis you made, then you will think about your usual drug you prescribe for every patient because you trust this drug. But then you discover with the AI that the drug you are used to prescribe is not compatible with the other medication of the patient, or it's not compatible with its comorbidities. Then you have two options, for instance. I just give you an example. Choose another treatment for the new diagnosis or switch a previous medication to another one so that all medication are compatible. This is a great example of two ways you have, and you will have to decide which one you wanna select. That's the analogy, the best analogy I can tell you for the ways. But physician has also his trust with one or several medications, just like you have a trust to one direction or another to go to your best restaurant.
Sounds good. All right. So the danger of analogies is taking them too far. But I'd probably rather go to rather go to a restaurant where you live than where I live. So maybe that would be a good thing. We'll have to do that together next time. Let's talk about voice. So you mentioned AI and voice as both being ways to get over some of these challenges of all the clicks. What, separate from AI, what makes voice a good technology? Why have physicians adopted it?
As I said, that shortcut the complex interfaces where you have many options, and you've seen in the last conferences, even outside of healthcare, that people think about like switching from one software to just like something you will hold or keep in your pockets. That's somehow the same way like EHR publishers, EHRs being like electronic health records, are thinking about the future. So voice is everywhere. Voice enables you to control your software. But for the prescription side, because that's why I'm interested in. I'm a pharmacist, so I maybe like too much focus on medication. That will enable just to dictate the prescription, your way you think about it, and always have this assistance of an AI telling you that you are prescribing the right drug, the right dosage, or there may be options to optimize a prescription, or there is a huge risk in what you've said, and you should absolutely correct it. So the way it works in terms of a user journey, that you prescribe, you get the control based on your patient profile, you validate, and you send it to your software, or you correct and you send it to the software. But there is always this step where physicians can correct or validate the prescription. Sorry for that, before you send it to the electronic health record. Yeah.
So if I think about, so you have this new collaboration with Microsoft, and it's their Nuance division. Nuance started off as really a transcription company. They used to take in the dictation when it was analog, and then they would, type it up and they would provide it back. And then they evolved, and then it was eventually acquired by Microsoft. And they do focus. I mean, they're integrated into, they're integrated with this Copilot kind of an approach. So they're using AI in the first place. So why did Nuance need to work with you? Why does Microsoft need to work with you as opposed to just including within Dragon your functionality?
Yeah, the prescription part is probably the most complex step in the I would say the use of your software. you will use your software indeed to write down the report of your patient-physician's conversation. You will click in the software to select the diagnosis you made. But prescribing is a long process, as we said before, but also the most difficult step in terms of adapting and making the right choice. So here, adding POSOS to their portfolio somehow of solution, like partners, Microsoft is able to cover the whole patient journey in a physician office, from the first discussion with the physicians, also the control of the software with Copilot, and at the end the prescription, which is always the last step of a consultation. So it's a way for them to cover the whole patient journey. I think that's the first reason. And this very clinical part of the patient journey and physician interaction with the software is very hard for them to cover, just like Microsoft competitors, because you've seen that there are many competitors now on this Copilot technology. And what you need also is a drug database to perform that, because the way we manage this AI assistant for prescribing is to have a worldwide universal database covering all medication from all countries, covering all languages, making it possible to correct a prescription that anyone in the world will make. So that's the way also Microsoft think about the future, being able to scale every solution they partner with. And I think we are the best position in worldwide to enable that. And that's why they decided to collaborate with us. It's more for it's not only for the use case we provide, but also the possibility to scale the solution everywhere. And I will tell you one funny story. I had last week a conversation with a Swiss EHR publisher, asking if we can cover the 3 languages in Swiss, which are French, Italian, and Swiss German. Yes. And Swiss German is a very interesting language because it's written exactly like German, but they pronounce it in a totally different way. So we can manage the German part in our software, but we are not able to cover the Swiss German way of pronouncing the prescription. So also from our side, Microsoft was the best partner to make it possible to use POSOS everywhere.
Oh, that sounds good. Well, so, Microsoft, obviously a global company, and you're talking about the ability to scale and what the needs are. And at the same time, healthcare markets and, the healthcare system is pretty different from country to country. Certainly the US versus Europe broadly, but even France versus Switzerland or other countries in Europe and then Asia are different. What do you find is the same? Is it very universal what you're doing, or are there certain things that need to change, not just based on Swiss German, but based on the actual structure of the healthcare system or the financing of it?
Yeah, the clinical part is the same everywhere. You will decide to prescribe one drug or another. You will diagnose a pathology the same way in the US, in Europe, and in Asia. So the drug database we've developed, for instance, is not populated with text fields, but only international codings, which are the same everywhere in the world. So the clinical information we have is available and compatible with every country. The big difference is, of course, the patient journey in the system, and also the price sensibility or reimbursement sensibility. And somehow, coming back to the Waze analogy, in Waze, sometimes you also have different options based on the traffic. So here, I think for the US, for instance, you will have also to select which one drug or another based on the possibility for the patient to be reimbursed or the possibility to afford this prescription. So it's like an additional type of data that you have to process in your prescribing assistance, taking into account a patient insurance coverage, for instance. But at the end, the act of prescribing is really similar from one country to another if you just take into account these economical points as well.
You mentioned your background as a pharmacist, and one of the things pharmacists are typically concerned about is medication reconciliation, which is a big challenge. And I'm wondering if you could just describe from your perspective, what are the issues with medication reconciliation, and can AI be helpful there, whether or not POSOS is doing it?
I'm not sure it's a very different process to the one we described before for prescription. The main issue actually is that physicians or pharmacists are partially blind because they are not fully aware of what the other physicians have prescribed or what the other pharmacist has given to the patients, and so that the decision they make in terms of prescription or giving a medication to a patient could be wrong just because of his blindness. I'm not sure that the AI is the right solution for that. It's more about like sharing information between all health system or physician hospitals and together with pharmacy. So once we will have a common electronic health record shared with every clinicians, I think this reconciliation problem won't stay. So it's a question of sharing information to have the whole picture, and then the right prescribing assistance to take into account this wider information that will be available.
Emmanuel, my final question for you is about the vision that you have for the future. You've obviously just had this very exciting announcement of a collaboration with Microsoft, the potential to scale. Where do you see POSOS in 5 years?
Well, yeah, I announced this Microsoft collaboration, but I didn't talk about the collaboration we have with EHR publishers worldwide. There are already 18 EHR publishers working with POSOS who embedded the solution into their interfaces. So the vision we have in 5 years is to have not only the only drug database that is really like universal, as I said before, this capacity to prescribe with POSOS with a voice or with your keyboard with a suggestion to automatically populate your prescription. But really, we want to be the central point, like enabling not only EHR publishers, but also every medical app, every medical software to scale, because using POSOS database, using our APIs, is a great way to have the same software everywhere in the world. And that's the huge problem currently. Software are country-based because they are based on a country-specific drug database, where software are basing their technical stack on a solution that can scale by itself. Then they can have a real SaaS model and replicating their solution everywhere in the world. So we think about a more intentional software and that will be available for every physician in the world. That's not only POSOS, it's POSOS together with a partnership, but we provide the great technical product for that.
Well, great. That's it for yet another episode of CareTalk. We've been speaking today about AI and drug prescribing. My guest has been Emmanuel Bilbault, co-founder of POSOS. Emmanuel, thank you for joining me.
Thank you, David.
So if you like what you heard or you didn't, please make sure to subscribe on your favorite channel.